Welcome to Interviews with the Experts. I'm Kyle Klarich, and I'm a consultant in cardiovascular medicine at Mayo Clinic in Rochester, Minnesota. And today we will be talking about an important application of AI ECG in valvular heart disease and diastolic dysfunction. It's my great pleasure to introduce our expert and my good friend and esteemed colleague, Dr. Jae Oh. Many of you are probably very familiar with Dr. Oh's extensive contributions to cardiology. Dr. Oh currently serves as the director of echocardiography core laboratory in Rochester and across the enterprise. He's the director of the pericardial clinic and co-director of integrated cardiac imaging at Mayo Clinic. Dr. Oh holds distinguished professorship, which is a named professorship, the Samsung Medical Center for Samsung-Mayo Clinic collaboration, he was the founding director and general director of the Heart Valve Stroke Institute at the Samsung Hospital in Seoul, Korea. So he has done a lot to advance not only cardiovascular medicine in the United States, but internationally as well. He has had over 500 manuscripts, including widely recognized textbook, the Echo Manual, and he has received numerous honors for teaching, innovation, research, and notably, Dr. Oh has been awarded the Lifetime Achievement Awards from both the European Society of Cardiology and the American Society of Echocardiography. Throughout a long and respected career, Dr. Oh has been involved in many facets of cardiology. Most recently, Dr. Oh's research interests have expanded to the application of AI ECG, which is a focus of our today's podcast for Interview with the Experts. I am really excited about this topic. AI ECG has become the go-to potential to turn a ubiquitous and actually a low-cost test in medicine into an early warning system for silent heart disease. I can tell you that we are going to be very well appraised about this by Dr. Oh. He has had many conferences on this, and I personally frequently use our tools at Mayo Clinic to guide my practice. So Jay, welcome. And thank you very much for joining us and enlightening us about this very interesting topic.
Thank you, Kyle, for a generous introduction. And then I'm honored to be part of this podcast with you. So hopefully we have a good discussion. Thank you.
Yeah, I think it's very helpful to know, how did you, after all the research you've done, get involved in AI ECG for both diastolic function and aortic stenosis?
I think underneath all my efforts, I like innovations, and I like new progress in medicine. And I remember taking course of Fortune Computer, an undergrad many years ago. But as you know, I am an echocardiographer. That's my special interest, and also the clinical interest has been diastolic function and valvular heart disease and the pericardial conditions. Clinically, and also I've been running, as you mentioned, echocardiography core lab for many years for the clinical trials, and that particular responsibility really requires standardization of how we acquire and measure and interpret echocardiography, and also the excellent quality assurance. So initially, I thought when AI was coming, into our innovation field, I thought AI would be an excellent tool to really standardize how we measure echocardiography and how we use for the clinical trials, which really requires a standardization. That was how I really got started my AI thinking, and then. As you know, the Mayo Clinic, has been really fantastic with innovation in AI, really under the leadership of, our chair, Dr. Paul Friedman, and then Zaki Tia as an engineer, principal engineer for AI for many years. And I was really fortunate enough to be part of the team several years ago. And then I realized that actually this is on electrocardiogram. My interest is in echocardiography, but I really found that having a good knowledge in echocardiography is really quite essential for developing good AI program, maybe not only the ECG, but many other imaging technologies because of the fact that now we use echocardiography as really a reference tool. That is the sort of final diagnostic reference that we use to develop other AI. So it's really important that we know the echocardiography well. And that's how I got really involved. And I've been feel very fortunate actually because I really enjoying the progress and the things we created for the last few years.
That's fascinating that you started with really a very sophisticated imaging tool, but then went back to what we call the humble EKG to really develop a couple of very important algorithms. How did you develop the AI ECG algorithms?
Yes, so when I was talking to our AI team, since my special clinical interest has been diastology and also valve dysfunction, heart disease, I actually volunteered that I want to do those two area of ECG because ECG is, we use for ST elevations and then arrhythmias and then T-wave inversions and all that thing. Kind of a obvious the things we see on electrocardiogram, but I didn't really realize that many different segments of the electrocardiogram by itself or permutation of all different segments really reflect what's happening in the heart in terms of functions and then structures and also the hemodynamics there. So, when I expressed my interest in those two areas, they introduced me to excellent engineers, and I just want to have to really recognize the two engineers that I work with, the Mikhail Cohen-Shelley from Israel. She worked on the valvular heart disease, especially aortic valve stenosis, AI ECG with me, and also subsequently Dr. Eunjung Lee from Korea. She is also the PhD engineer and came to Mayo a few years ago, and I was fortunate to work with them. And kind of interesting that for us to really develop this AI program, I'm just talking cardiology, I need to understand some of the technology that how our engineers developing because although they are creating all the programs. And I also thought that it's important that our engineers really understand the clinical aspect of the what we are trying to do, because we don't want to develop something that clinically is not useful. We really have to use this one for our practice. So what I did with both of them, engineers, when I talked to them, initial interview, we talked to them, I gave my echo manual book. It's a 700-page book, but I said, you really have to read, may not be all of them, but you really have to read this echocardiography textbook, which has not only the technique of measurements, but also the clinical implication of what we measure. And that's how you have to program the computer that develop AI programs. So that's how I start doing it. And actually, it's very impressed that how quickly they were able to really understand the clinical aspect of what we are creating as an AI program. Because for us to create AI, we have to come up with different criteria, the mild, moderate aortic valve stenosis, severe aortic valve stenosis, the gradients and valve areas, and then the DVIs, a lot of parameters. The more challenging thing is the diastolic function. How there's a lot of debate, many different algorithms to do that. So we really spend a lot of time talking together, not just the technology, but how we define certain things that, diastolic function, what parameters we're going to be using, and what patients to include or exclude. But at the end, we decided to not exclude anyone. We include everybody who has the electrocardiogram and echocardiography within a couple of weeks, and then we end up getting almost 300,000 patients from the Mayo Clinic database. And then we really train. I don't know whether I can just share with you a couple of slides that I think it'd be helpful for the listeners and the viewers to see that. This is the training portion of a diastolic function, and we use almost 300,000 patients, and we use about 100,000 patients for the training. So, engineer and we as a team, we label every single electrocardiogram based on the echocardiographic determination of diastolic function. Okay, and then we put that determination through the convolutional neural network CNN to create this AI model there. So, that's based on about 100,000 patients who had the electrocardiogram and echocardiography within a couple weeks of each other. And then we tested it and validated using another 100,000 patients there. Now, when we see new electrocardiogram, as you mentioned earlier, that now in our practice, we have ECG. Within 5 minutes, we can get this dashboard of showing not just only diastolic dysfunction, but many different cardiac pathologies. In this particular case, in diastolic function, it shows in our dashboard grading of diastolic function is normal or grade 1, and then that classifies normal filling pressures. And then the other side is the increased filling pressures and grade 2, grade 3. And that's what we see every day in practice. And then when you look at our performance of this in testing in about 100,000 patients there, this is what we achieved. AUC of 0.9 for detecting high filling pressure, separating from the normal filling pressure, meaning wedge pressure more than 15. And then it's also impressive that the AI ECG was able to separate grade 1 to 3 from normal diastolic function with AUC of 0.85 to 0.94. And then sensitivity, as you see here, with 83, both of them showing that. Just show two quick examples we do here is that this is a patient who came to emergency room. And of course, patient comes in the emergency room with a short of breath, they'll get an echocardiogram sooner or later. It's hard to get an echocardiogram in the emergency room or in the office, right? But when they get an echocardiogram, this patient clearly has a very restrictive diastolic filling with high pulmonary artery systolic pressures, and strain imaging shows sort of amyloidish, sort of apical sparing. But if you do the electrocardiogram of this person right here, and it shows our dashboard says high probability of amyloid, and the diastolic function is grading is a grade 3. So, it's kind of amazing to see that the 12-lead electrocardiogram is able to see the probability of certain cardiac conditions and also the degree of diastolic function grading. And then because of that, we did a further study in the pyrophosphate showing the ATTR amyloidosis. And then another example I just want to show as last, this is a problem that we got into aortic valve stenosis because many of patients with a valvular heart disease, more than half of them, they do not know they have a valve disease.
Right, that's so true.
Yeah, this is a patient live around the Mayo Clinic. I mean, an hour from us, and first presentation to us was cardiac arrest, and then we found that he has a critical aortic valve stenosis, as you see it here, and then ECG at that time shows very high probability of critical aortic valve stenosis here but the last electrocardiogram was 2015, 10 years ago, and the chance of AS was not there. And if he came to us somehow in 2020, we could have gotten him earlier, and then we able to manage his aortic stenosis without going through this whole the cardiac arrest and things like that. So that is where I think the main power of the AI is going to come, and that's how we able to develop this AI ECG program using the echocardiography as a reference diagnosis.
That's very instructional, I think, in terms of how we do this. I go to the training set first, where you know the diagnosis and you throw all those EKGs into the training, you know what the answer should be. The EKGs are read by the computer basically.
Yes.
And then there's something in that package too that's a convolutional neural network.
Yes.
I think that a lot of people stumble over that. Do you have any quick and easy understanding of what a
It goes to the
convolutional neural network?
It goes multiple stages there, and it just detects selects out the common things that associated with that particular diagnosis, and going through the multiple stage. I think the more stage you go through, you're gonna be more accurate on that. So initially, it would be kind of a generalized morphology or combination of multiple parameters, and the second stage will be a little bit finer. So we go through 8 to 10 levels like that. Then we hope the final product to be the one that we can use in clinic.
Well, you showed that it was very highly sensitive and specific, and that the negative predictive value is very high. And then those that come out of this positive, they need to have further investigations. It's impressive too how many studies you really do need to train the system and then validate the system using that. But I think
that's really the treasure of what we have at Mayo Clinic. We have fantastic filing system, and then we have archiving system. We have millions of echocardiography here. We can just retrieve any time within a few minutes, and then we have all the archiving system from Dr. Plummer's period of many years, 150 years ago. So that's where we have advantage over other institutions because you got to put the good data into the CNN or those machine learning to come up with good data, right? So I think we've been very fortunate to have that data.
I think something else you said earlier in this discussion, I just like to highlight for the audience, is that the convolutional neural network, when you're training it, is also looking at parts of the EKG that we don't typically read, the kind of the flat lines between the QRS and then the T wave, and then the flat lines between the T wave and the R wave, the P wave, and different variations of any of those waves that we, don't really exactly read in the same way that the computer may see them, but somehow pulls all this together in addition to the stuff that we would classically look at, like LVH and T-wave inversions, as you mentioned. I think that's a really important point, if I understood you correctly.
Yes. I think that is, everybody or many people, when I talk about this, ask, that's first, which part of ECG does computer look at? And we try to get to that, but it's very hard. And we realize that when we get the salience map and things, actually what the computer does is really segmentalize the ECG to multiple segments, and they combine all those segments. Permutations is the product of the CNN. And it's interesting that when you look at the normal grade 1, grade 2, grade 3 for diastolic dysfunction, they don't look at the same segment of a TR, the PR segments or QRS duration, whatever. It's a permutation of multiple segments there. So what the computer looking at for the grade 1 is very different from what computer looks at for the grade 2 and grade 3 diastolic dysfunction. So it's I don't know. I'm very curious what the computer really look at, but it's very, very hard to know that, because it's just so many segments there. Well, there's a 12 lead, a lot of duration, is a depth and then amplitude, all this stuff.
Right. Yeah. No. I've heard that time and time again with these programs, but it is, I think, very important that you have a very large training set, and then you have a validation set, and in between that, the convolutional neural network has done I'll just call it magic for right now. Sometimes it's referred to as a black box, but I think that this is very interesting because the computer doesn't get tired. It just looks at everything. Whereas if you and I try to look at these EKGs, with the pressures of time and so forth and so on, we aren't able to see the same things that the computer can see. So it's fascinating.
Yeah, I think the more important thing is, we may not learn exactly what the computer look at because it may be too complex. But the more important thing is we need to prove the clinical application and efficacy for patient care. That all the prospective and retrospective trials that this one, helps in our triaging and prognosis and management. I think that'll be the key for future to do that, I think.
Yeah, well, it's been a fascinating discussion. Maybe I'll just end on this question. What do you think the optimal clinical application of AI EKG will be?
Actually, I have to tell you, we've been doing multiple studies using this AI ECGs because, as you know, the aortic stenosis is a little bit more challenging because I think it's the positive predictive value really relies on the prevalence of disease. If someone has only 1% prevalence in population, it is a little bit harder. Negative predictive value is really nice, but the positive predictive value is very small to pick up 1%. But the diastolic function is interesting because everyone has certain diastolic dysfunction, what is normal, 1 or 2, 3. So the value of that has been very, very nice. And then another important thing is that diastolic filling pressure elevation is a common process for all left heart disease, whether it's the valvular heart disease, AS much regurgitation, or HEPAP patients, and then cardiomyopathy. Anything on the left heart, problem, a short of breath, you have a high filling pressure, and then the diastolic function becomes abnormal there. So we now have shown that prognosis of AI ECG in the mitral regurgitation we published in the JACC last year is actually superior to the regurgitation volumes or severity of MR because it also detects the superimposed myocardial disease together. Because a patient comes to us, valve disease, also hypertrophic cardiomyopathy are specialized, and they don't just come just that particular disease. They also do have a superimposed problems on the top of that with the kidney disease or hypertension. And I think the diastolic filling sort of put everything together and then finalize the outcome. So we are finding it's been very helpful in patients with the emergency shortness of breath, and it has been very helpful in prognosis. And the most important thing is now our outside colleagues. I was very impressed that our heart failure leaders in this country, especially at the Brigham, Dr. Desai and others, used our AI ECG systolic function, diastolic function program, the algorithms, and apply those 2 AI ECG algorithms to the retrospectively all the NIH heart failure trial patient group. But I think it's almost 14,000 in patients with the Framingham trials, MESA trials, and also CHS trials. And then that colleagues there apply that and compare that to the prevent heart failure scoring system they developed from their clinical work to identify patients who develop heart failure 1 year, 3 years, 5 years, 10 years later. And he presented this data and then published in the JACC last month simultaneously as a late breaker that actually the AI ECG diastolic function was the most predictive of developing heart failure 1 year, 2 years, 5 years later with a significant incremental value to the clinical scoring system. So I was very flabbergasted actually because it's coming from Mayo Clinic. Our product is one thing, but this is really validated by the other clinicians in heart failure leadership that using NIH clinical trial patients to really prove, validate the usefulness of the AI ECG for identification. So I think it'll be a fantastic, in valvular heart disease, I think generalized screening for the patients with the significant AS or mitral regurgitation will be important. And the diastolic function will be important to predict or identify patients with a future HEPAP, patients with develop some sort of heart failure later on. I don't know whether we can prevent it. That'll take a significant clinical trials later on, but that's our hope that we can use this AI ECG as a screening tool and prevention and management. And also we use the 12 lead, but we also know the 1 lead especially lead 1 works reasonably as well as the 12 leads. So hopefully this can be wearable that even patients with heart failure, they can detect their increased filling pressures, and hopefully they can manage their diuretics and some other medical therapy to lower their filling pressure to feel better. That would be my actual hope that clinically they can be used, can be used in future. Anyway.
That's a really beautiful view into the future of what is possible once we go through the very rigorous teaching and then validation and then revalidation and intra and across institutions, across different patient populations. And, one of the reasons I'm so excited about it, because you can take something that most patients will get from their clinicians, from their family physicians, their primary care providers. And then if that has a signal, then those patients can go on for escalated testing and allow us to determine, what to do at that point in time.
I just forgot to mention one thing because of the hypertrophic cardiomyopathy that you're expert on. because I got a call from Dr. Sheff. I mean, he's the outstanding surgeons that who have done so much work with the myectomy for hypertrophic cardiomyopathy. And actually, he somehow got interested in after he looked at our data, he applied the AI ECG diastolic function to his patients that he operated on with hypertrophic cardiomyopathy with a myectomy. And then he showed, and he's published actually a couple months ago, that AI ECG diastolic function at baseline was the most prognostic for those patients with hypertrophic cardiomyopathy after myectomy. So I think I was really impressed that even our cardiac surgeons now, and then Dr. Chris Nello, he's also interested in looking at the AI ECG for AS and diastolic function in patients with aortic stenosis to see how that changes
right
for the surgical and the transcatheter AVR. So I think we'll come up with a lot of interesting applications in the future there.
I know. I think we ignored the ECG a little bit for a while there in our practices, but now it's becoming front and center, and it's a really exciting time in medicine in general, but in cardiology in particular. And thank you for all the amazing work you've done in this field, not only in the AI ECG, but lifelong work of helping us better understand diastology, helping us better understand pericardial disease, valvular heart disease, and everything else you do. So it's been a great pleasure to have you here. I hope that our audience has gained as much information from this as I have, and we'll welcome you back to another interview with the experts at a later date. But thank you again, Jae, for participating today. And we wish all of our listeners a fantastic day, week, month.
Okay, thank you so much for having me. Thank you.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Benjamin Hibbert, Chair of the Division of Critical Care Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for you and your patients. Head to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.